This is my journey. Inspired one story at a time, a library of leaders was created. It began as a journey to learn. As time went on, it began to grow. All it needed was a platform, and this podcast was created to listen, to inspire, to share. I am a storyteller, and this is my journey. Welcome to another episode of Profiles in Leadership. I'm your host, Steve Anderson, and this episode is brought to you by Silna Health. That's S-I-L-N-A, the premium front-end RCM company that leverages technology with a team of onshore insurance experts to handle benefit checks, eligibility checks, and prior authorizations. Finally, a vendor that you can trust, like a full-time employee that scales with your business. Just mention the Profiles in Leadership podcast to receive a free trial. And today our guest is Dr. Rebekah Griffith. She is a physical therapist who specializes in care at the emergency department of a hospital. Dr. Griffith believes physical therapist practice in the emergency department is a critical way to move upstream in healthcare that supports patients during their most critical moments. She is the author of Top of Scope, the Emergency Department Physical Therapist Handbook. She is a board-certified neurologic clinical specialist and a fellow in training at Regis University. She serves her profession as the incoming APTA Colorado President, but her real-life work is raising her 3 spectacular children. So, Rebekah, thanks for being on the program today. It's great to have you on.
Oh, I'm happy to be here. Thanks for having me.
So why don't you just give us a little context, a little bit of your history, where you grew up, where you went to school, and how you kind of ended up where you are today.
Sure. I was actually born in Colorado, out on the plains of Colorado, but grew up in a few different places, Utah, a little bit in Ohio, a little bit Washington, D.C. And then we moved back to Colorado when I was in high school. So if you've ever been to Estes Park, Colorado, that's where I went to high school. It's
Okay.
a gem of a place right by Rocky Mountain National Park. And my dad actually had his legs amputated while I was in high school. And that kind of threw things into the wind a little bit. So at that moment when I really needed help trying to figure out like how to apply for college and how to get financial aid and all of those things, like that support just wasn't really available at that time. So what I did instead was graduated early and then just started working so that I could figure out what I was going to do next after a little bit of a pause. And then during that time, I got engaged and got married and decided to stay in Colorado. So I went to college after my husband graduated and I went to CU Boulder. Go Buffs.
Uh-huh.
Yeah, after that, I went to PT school at the University of Colorado as well.
That's awesome. Now it's kind of hard to go to a party school like that after you're married, so that must have been an adjustment.
It was, and it's funny because one of my kids is 15, and so he's looking forward to asking questions about college and things like that. And I'm like, I don't know if I'm the best person to ask these questions to because for me, college was a job. I graduated college early as well because I had a house, I had a husband, I didn't live on campus, I never spent a night in a dorm. Like I did go to a party school, but I just didn't do any of that. So I don't have that experience. I kind of wish I had done it more like a life experience than like a job, but I felt like I needed to get my life started. And so I went through that like a business. I'm going to encourage my kids not to do that though.
Yeah. Well, there's a lot of growing up to do at college, that's for sure, but it seemed like you were well on your way to that. So how did you get interested in physical therapy? Was it because of your dad's what he had to deal with, and did that spark your interest?
I think some of that. He definitely going through that process. He had a total ankle replacement that failed 5 times. They revised it 5 times, and ultimately that ended in an amputation. And then the other ankle, rather than go through that stress again, he was like, well, let's just amputate both of them and move on. And for me, it's like one of my favorite things about physical therapy are those second first steps. And so when you get to see somebody learn how to walk again, it's very inspiring. But actually, I was working at Merrill Lynch before I went to college. I was going to become a broker. I was going to sit for my Series 7. Like, I was in it to win it. But then 9/11 happened, actually. And my facility shut down as a result of that. And my husband was graduating from college, and it was like, okay, you can do whatever you want now. If you want to go to college, you can go to college. If you want to pursue your brokerage license, you can do that. So I thought about that for a while, and I thought, what is the job that I could do that would inspire me, not make me have to sit in a desk all day, and like really give me some ability to make a difference? And physical therapy was where I ended up.
That's amazing. So you graduate from PT school. What was your first job out of PT school? I doubt it was in the emergency department.
No, I actually worked at Craig Hospital, which is a world-renowned brain and spinal cord injury center. So that was what I did. I was on the combo team and I did acute rehab for patients with brain injuries and spinal cord injuries, usually both at the same time. So that was a really interesting way to start. It was intense though. I wish I had focused a little bit more on becoming a generalist rather than diving right into being a very niche specialist at that point.
Well, and that's amazing work. I think that really takes very special people to do that work. I went to PT school thinking I was going to be a rehab therapist, and I was a floor above the Rehabilitation Institute of Chicago
Mm.
at Northwestern University. And after spending some time there and seeing, just the tragedies that were there and trying to work and just seeing such little progress and whatever, I kind of determined right away that probably wasn't my thing. So I went on to be an orthopedic physical therapist. But what you're describing there is that's tough, hard work that takes a lot of patience and like I said, you're kind of doing God's work there.
Well, I think you're exactly right. And that was a problem for me. That holding the grief of people was a problem for me. I treasure the experiences I had there. I'm still friends with some of my very first patients, but at night I would go home with this like profound sadness that I had been absorbing from people, and it really became really heavy. And I think that kind of colored some of the directions that I went to next, because I felt like when I got home, I didn't have a whole lot left for my family because I was emotionally exhausted. And so choosing things where I had more short-term episodic care, like I did outpatient orthopedics and neuro for a little while as well, but that still was a lot of relationship building, and I felt like I was so invested in everyone's outcomes that when I finally ended up in acute care, which is a thing that I swore I would never do, I loved it because you really get to see a patient one time, you give them the best that you have, and then you like wish them the best and you move forward. And for me, emotionally, it's much easier for me to compartmentalize like that.
So tell us how then you get interested or even have a chance to work in an emergency room department, because that is certainly not typical physical therapist place to work. And you're, I think, one of the few, and we'll talk more about that as we go, that do that. But tell us how that came to be.
Well, I feel like now you can just apply for a job as an emergency PT. It's becoming so much more mainstream, so much more popular that they're actually having trouble finding PTs that are interested in doing that work. But for me, after I had my kids, I had my oldest son, and I was like, well, maybe I just want to work per diem so that I can kind of support my family. And a former classmate of mine was like, "Hey, do you want to come work per diem at the hospital with me?" And I was like, "Oh, gross. Like, no, no, I don't want to do that." But when I looked at like the salary, the schedule, the flexibility, and balancing all those things, I was like, "Okay, I can learn how to do this." But I have to tell you, I did not want to do that. Like, I didn't do any clinicals in that setting. I like was pretty anti-hospital, which is hilarious in retrospect now. And it took a lot of getting used to, but because I was a per diem therapist, I was kind of what I like to call the grout therapist. You fill the cracks. So they would send me to a different floor every time I was there. And so my skill set expanded wildly, and my ability to evaluate anything like just kept growing and growing. And as part of being that grout therapist, sometimes the cracks that needed to be filled were in the emergency department. But those cracks started getting bigger and bigger as it became harder and harder to admit patients to the hospital. They couldn't quite send people home. It's like the immortal words of Semisonic: you don't have to go home, but you can't stay here. So we were getting called more and more to come and like fix that problem. But that would mean my patients, like in the ICU, weren't getting the care that they needed. So at that point, I started a pilot program to sort of prioritize having a full-time physical therapist in the emergency department, not only to address those discharge problems, but to really address all patient care needs that a physical therapist can address.
So walk us through a typical day in the emergency room with you being the physical therapist. So just, what do you see? What do you do? Just kind of walk us through a typical day so we know what it's like.
Yeah, I think the first thing to say about that is there is no typical day. If you're the kind of person that likes to know what your schedule is the day before, you want to plan out your treatment plans ahead of time, this is not the job for you because you just have to walk in having no idea what's going to happen and be prepared to take all comers. So, typical day would be coming in. I would say the first thing I always do when I come into the emergency department is I round with all of the medical providers. I walk around and I say, "Hey, I'm Rebecca. I'm the physical therapist today. This is what I can help you with. Please consult us if we can be of assistance." That way, you're kind of present in their mind. They're thinking about, "Oh, this is a thing I can offer my patients." And then we take a look and see if there are patients waiting. Sometimes there are patients that are held over from the night before who could not be discharged really safely without seeing a physical therapist. So we'll address those as well. But then we also have areas of our ED where we're going to get a lot of musculoskeletal complaints. It's kind of people who should have gone to urgent care. So we'll see a lot of back pain, or we might see some ankle sprains, or we might see somebody who fell down the stairs and has multiple new fractures, or a patient with a total hip replacement that's dislocated that. And how can we help after that reduction to get that patient back up, out, and on their feet? We also see a lot of patients with vertigo. So we'll do a lot of differential diagnosis from that perspective. We'll assess people with complex medical needs to see how are their vitals when they're mobilizing? Are they not thriving at home because, as it turns out, they're hypotensive and hypoxic when they're trying to go up and down the stairs? Or we have a patient, say, with congestive heart failure who's coming in volume overloaded. And if you ask them, have they been taking their Lasix? They say, no, because it makes me have to go to the bathroom and I'm afraid to fall when I get up. So I've just stopped taking them. So not only is this patient now volume overloaded, they're not walking, they're falling, and they're getting sicker and sicker. So we'll intervene with those kind of cyclical chronic disease loops as well. And then the classic, this person fell at home, are they safe to go home?
So you work in a large academic hospital, is that correct?
I do. I work in a level one academic trauma center in the Denver metro area.
Okay, and so how many physical therapists work in the emergency department of that hospital?
We actually run 3 a day, Monday through
Okay.
Friday, and
Wow.
one on Saturday and Sunday. We also have a full-time occupational therapist.
So now, am I just maybe naive? Is that unusual, or are you seeing that across the nation?
I would say that it's increasing, but I would say 3 is probably pretty unusual. We have a very large emergency department with over 100 beds in it, so we do have quite a few. And if one of our therapists does not have enough patients to see, we'll go assist our colleagues on the other units of the hospital. But I'm seeing more and more ED PT practices where you're going to have two therapists, maybe on a split shift, where there's some overlap in the middle, but then they get the day covered a little bit better. So we're seeing more of that. And as practices continue to grow and we're able to demonstrate the value that we have, we're starting to see more and more therapists. Also, when you think about it, the emergency department really is the gateway to your health system. And resources are also scarce. So we're not trying to admit people who don't need to be admitted. We're not trying to do tests on people who don't need them. So having physical therapists there at that first level of decision making about who really needs to come in and who can go out and what do they need, this is a great place to allocate some of those rehab resources.
So do you feel like a little bit of a maybe promoter of the profession at that stage too, of telling people what physical therapy can do and maybe open their eyes to something they never thought of before?
Oh my goodness, that's one of my favorite parts. And I'll tell you, it's funny because one of the physicians that I work with said, "Why did I have to figure out you were a daughter or a doctor on Twitter?" And I was like, "Oh my God, like every PT that works here is a doctor." And so that was a really good opportunity to have a conversation about what our training is, what our scope of practice is, and how we can really support you. And once they can see that your skill set, like the breadth of that skill set, that we are like experts at the musculoskeletal system, for example, and they know that they're not, they're more than happy to leverage that expertise. But you also have to remember that emergency medicine physicians don't get a ton of exposure to PTs in their training. they're not like orthopedic surgeons or neurologists or pediatricians or anyone like that. They really don't know what we can do. So once we show them what we can do, they're on board. The hierarchy in the emergency department is also very lateral. Emergency medicine practitioners are very used to consulting others. Their specialty is stabilizing people and make sure they don't die. They are more than happy to call neurosurgery, to call orthopedics, to call like hematology, whoever it might be, to get that expert consultation. And we are just like those experts. So we are treated just the same. One of the things our providers say is, this is Dr. Griffith. She's the physical therapist. She is going to evaluate, treat you, and set your plan of care. And I'll be here to provide any support as needed. And that really sets your patients up for success as well.
So it just sounds like one, it's kind of a dream situation, where you're working with colleagues that treat you as an equal. You just, you go forward building these relationships, and you're also working at the top of your license, it sounds like.
For sure. And I also think it's a prime place to educate patients on what we do. Because so many of the patients that come into the emergency department may never see a physical therapist any other way. There's a reason they're coming to the ED most of the time. So we're able to see more people, provide them with that little bit of taste of physical therapy. And we've shown that if you see a physical therapist in the ED, you're way more likely to follow up to that outpatient PT visit because we've provided that value and they're like, oh, I need some more of that. And so we're able to get those patients connected longer term to services that they might not have even thought that they needed. So I love that.
So let's talk about relationships a little bit, with colleagues in that situation. Again, I think of an emergency room as chaos, people under pressure, people very heightened, as far as emotionally and get to action and whatever, which can sometimes make it harder to build relationships with that. So I would assume that you have to be quick on your feet. You have to be willing to, um, take direction, being barked at once in a while, and so on. And so it's just tell us a little bit about what it's like when a real trauma patient comes in like that, and there's just all kinds of things going on at once.
Well, I would say that most emergency departments are very good at not letting you know when things are stressful. So that's why whenever I hear patients complaining, they're like, oh my gosh, this is taking so long. Nobody's even doing anything. And I know that in the background, there's multiple patients coding, there's traumas coming in, there's helicopters expected. Like, I kind of love that it seems very calm, even though it's very stressful. But if you're in it, you can feel it, you can see it, and you know when to get out of the way, you know when it's okay to intervene. And I think the other thing too is to appreciate those moments of calm when they come. And you have to get very good at your communication and your flexibility, and you got to grow a little bit thick skin. And I would say the last thing is you have to know how to prioritize because limited time, limited resources, you have to be efficient and effective, not just one or the other.
And what about things, that wouldn't necessarily be on your specific job description? I mean, are you asked to do things that have nothing to do with physical therapy, but just because you're there and you're part of the team, you're going to assist?
I would say in the emergency department, there's no such thing as that's not my job. I mean,
Yeah.
obviously, if it's outside of your scope, you're gonna not do it. But I think a prime example of that was during the thick of COVID, I took some night shifts in the emergency department. And what my job was whatever was needed because I knew the department inside and out. So we had patients that were lined up on the floor because there were no chairs. We would have ambulances coming in, and I would get patients off the gurneys and put them on the floor or in a chair wherever I could find them, even though they had come in on an ambulance because there was no other alternative. And then I would start at one end of the row and I would take vitals and I would chart the vitals of everybody waiting. I would go all the way down and all the way back up. And by the time I made it back around, it was time to start again. But if you think about it, a physical therapist is a great person to be monitoring those vitals because I'm looking at the patient, I'm assessing the patient, I'm taking their vitals, I'm looking at change, I can tell how they're breathing, I can tell how in distress they are. And so part of that job was to say, hey, I checked this person an hour ago and their temperature was 100 and they were mildly tachycardic and their oxygen was at 90%, but now their fever is 104, their heart rate is 140, and their oxygen level is at 82. Like, we really need to push this person to the front of the line. So there have been all kinds of things like that. I can tell you, I remember a Thanksgiving day during COVID where my job was just to pull people out of cars. I was just the patients that drove up and couldn't get out of the car. I would go and like dependently transfer them out of the car and into wheelchairs to get them into the building. So those are some things. Another thing that a memory that sticks with me is we had a patient come in who had a significant fall from a height and had basically like kind of um, destroyed his ankles and he was getting splinted, but this individual was a former opioid user and did not wish to have any pain medication for the reductions and the splinting at all because he was so afraid of his addiction being an issue. And so my job was to use all of my skills at non-pharmacologic pain management, including de-escalation, pain neuroscience, meditation, just even holding this man's hand to help him calm down so that he could achieve his goal of no pain medication and they could achieve their goal of safely stabilizing his joints. And I won't forget that. Like
Yeah.
that's not something I'll forget.
Yeah, and so how long have you been in your present position in at your hospital?
I've worked there for, gosh, wow, 14 years almost, but I've been in the emergency department as my primary area since 2016. So about 8 years, just mostly doing the emergency department, but in and out of the ED before that.
And do your other colleagues, are they do they stay long periods of time in that setting, or is it kind of a come and go type of situation? What about your long-term relationships with other colleagues there?
I would say that from a PT perspective, that acute care is a transient kind of thing. There's a lot of turnover in acute care in general, but most of the team in the emergency department, there are three of us that have still been there since the very beginning of that pilot program, and we have a great team of therapists that have joined us since then because you have to have a big bench for the ED because, as you said, it's top of scope position. So you need to have PTs that are ready to practice at that level. And then I would say the harder part with like having colleagues outside of just the rehab piece in the ED is especially when you're in a teaching hospital, you're constantly starting over building those relationships, right? Because you have residents coming in, you have nurse practitioner fellows, you have PA fellows that are rotating in and out, you get new attendings, you get new med students. And so that's part of that job is that consistently having to build relationships, that networking, that marketing of yourself, that education of those people over and over again. But that being said, there are physicians that I've worked with the whole time, and I really value those relationships.
So, since this is a podcast about leadership, what you just talked about is building relationships and getting people to know what you can do and so on. So what is your strategy? I mean, how do you build the relationships and how do you show your strengths and share your gifts and just become part of that team? Is there a strategy, or do you think it's just who you are and it comes naturally?
Oh gosh, that's a great question. I would say that it's probably a combination of all of those things. But for me, I believe so strongly in what physical therapists can provide. I believe we can change the world if we can get out of the way of ourselves and if we didn't have payer-centered care, we would be able to just transform the world. So I believe that every opportunity, whether it's with another provider or with a patient, is an opportunity to change the world just a tiny bit. And so I think showing up that way, what can I provide? How can I provide that like spirit of contribution is really helpful when you're trying to lead in a specific practice area. And that ability to see beyond just what's right in front of you and think that big picture route as well. And I really firmly believe that we rise by lifting others. And so making that team work together for the benefit of everybody really is what I try to do in my practice.
Yeah, that's awesome. You said that very well, and what came to mind to me was that it's a perfect example of what leadership is. Number one, it's not all about you.
Right.
And number two, what can I do at this time to help the team? It may not be what you want to do, it may not be what you're best at, but the team needs me to do this now. And having that vision, I think, what makes a good teammate and somebody who then becomes a leader because people recognize that and appreciate that.
Well, I think that I know it's kind of a cliche, but that quote that leadership is an action and not a position is another way that you have to live your life. Because if you're constantly waiting for opportunities to lead, you're not going to find them. You have to lead from where you are with what you have. And I think anybody can be a leader no matter where they are or who they are.
So you referenced this a little earlier that one of the reasons you kind of like this approach that you're working in now is that you don't have a lot of follow up in the sense that you kind of own the relationships or own the people's feelings and so on. But my question is, when you do intervene with a patient and then they leave, do you ever have any follow up? Do you ever know what happens to him? Do you ever know what happens to him down the road in the healthcare system?
That's a great question because usually the answer is no. And I think that it's hard to know what your outcomes are like that, right?
Yeah.
So I'm in an orthopedic manual physical therapy fellowship, and one of the requirements of that fellowship is to track your outcomes. So I did for 6 months track my outcomes. And it was hard because everybody else is like able to track all their outcome measures and how many visits they used and everything. And my situation's not like that. So I tracked kind of what their diagnoses were, how I managed those patients, and then kind of what their 10-day follow up was. What happened in the next 10 days after they left? And I wasn't always able to follow that up, but I was able to see, did they get to that outpatient visit? Did they come back to the emergency department? Did they get their discharge plan? Did they follow the discharge plan of discharging to subacute rehab? I had one patient who, within that 10-day period of time, actually passed away. And so it was really interesting to me to see most of the time patients didn't come back, but sometimes they did. And that was a learning experience for me to be able to see, why did they come back? Did they come back for the same problem or a different problem? Did they come back because they didn't get access to the care that I suggested? So that was really helpful. We also have patients who I'd say are not frequent flyers, but patients who have no alternative to the emergency department. So we may see them somewhat routinely. We may see them over the course of years. And there are some patients that I feel like I've seen in 2016 who I see every couple of years, and I am monitoring their fall progress, their balance progress, their home safety. I know who home health has worked for in the past and who's been to subacute rehab before. So it's really interesting to track some of those things.
And so I know that hospitals also track, or maybe the hospitals do, but third-party payers really do, that the frequent flyers are the people that come back. So in other words, there's outcome studies that say, well, your department is successful if you have people come back less often, you know. And
Mhm.
so have you seen any research, or is it just anecdotal, or what do you think with physical therapy intervention? Do you think you can move that marker?
I absolutely, and I would say our unpublished data from our different pilot projects that we've done would indicate that during the course of time that we were seeing people, they were about 21% less likely to bounce back for any reason if they saw a physical therapist, and they were 50% less likely to bounce back for the same reason. So if you came in the first time for a UTI and you came back the second time for back pain, those were unrelated reasons. We were still able to decrease that return. But then if you came in for low back pain, you were 50% less likely to come back for it again in that 9-10 day window, which is usually what they measure that by. So we have seen some of that data.
So when you take like a severe low back pain and
Mm.
um, I'd probably make the argument that those of us that spend our careers in outpatient PT probably don't see the really painful acute low back pain that I'm sure you see. Um, do you think that just under trying to get a grip from the patient's perspective of what this is and why I hurt so bad, I would think would be an important part of your role so that they could just not, go crazy with all the fear that they have of why they hurt so bad.
Yes. So, I mean, if you had no other way to explain to people what you do in the emergency department, you just explained that so beautifully. I do joke with my outpatient colleagues that you've never seen a patient with acute low back pain. Sorry, not sorry. I don't think you've ever seen it. If it didn't take 4 firemen to get them in there prone on a gurney and they're still screaming, it's just, you haven't seen it yet. So having to take those patients who are screaming, who are stuck in one position, and help them regulate from here all the way down to here so that you can actually help them is a skill that you have to have in the ED, because EDs don't use a ton of pain medications. So you're not going to see a lot of just like immediate pain relief for these patients. They need you. And they're so scared. It's that what if moment that gets stuck in these patients' heads. That pain is so severe, it's so unexpected, it's so traumatizing and incapacitating that they immediately start going down this, what if I can't pick up my child? What if I can't go to work? What if I lose my job? What if it's like this forever? What if this pain never stops? So one of the first things I always do when working with patients is help them focus on what is happening, not what might be happening. And we go through that together and we rule out, we start with scary to not scary, and you can just see the relief. And I'll spend a lot of time just trying to get that patient in a position of comfort, because you cannot do anything to someone if they can't even hear or see you because they are so distressed. So that taking time to calm people and help them regulate so that they can begin to receive your intervention is half the battle. Then they can take that education and then you can get them moving. And my hope is that every one of those patients leaves the ED unafraid of their condition and empowered in how to manage it.
Yeah, you explained that so well. I think it's such a, you think of the outpatient world, I think physical therapists, we fall into the trap a lot of time of thinking we have to do something with our hands or we have to, whatever. And what you just described there was, what some people would think would be more on the psychologist level of just helping people understand what's going on and whatever. And, at that point, you putting your hands on them isn't going to make any difference until you get them in a state that they can at least like you say, calm down and kind of get their head around it, so to speak.
And patients are scared. I mean,
Yeah.
they're just afraid. They're in the ED because they don't know what else to do. And so if we can help them answer that question. I would say the uncertainty is the hardest for patients though. Like at the end of the evaluation when they're like, "So what's wrong with me?" and you're like, "Well, I don't know, it's specific low back pain." Like there's like they don't love that. But usually I can leave people with, this is not dangerous. There's multiple kinds of pain, the kind of pain that's damaging you and the kind of pain that just hurts, and it's safe for you to move. And the more you move, the better you'll feel. And it's safe for you to do that. And so many people just need to hear, it's safe for me to move. And then they're like, okay. And we had to do this like patient satisfaction survey during one of our pilots for being the primary musculoskeletal provider in the ED. And it's hard. It's hard to just hand somebody a survey and say, this is just about me. This isn't about anything else in the ED. This is only about me. And those patients where I felt like they had the most pain and I tried everything I could and I didn't really change their pain, I was so afraid to give those patients the satisfaction survey. But it turned out sometimes those were the most grateful people because they
Absolutely.
felt heard, validated, they saw you make an effort, and they weren't scared anymore. They still had pain, but they weren't terrified. So they felt like they could function. And that was such a good lesson for me. It was nice to get the
Yeah.
data, but the lesson was in how crucial our role is, even if we feel like we're failing.
You just brought up a couple of interesting memories from my career. I can remember once I had a PT that said, I just evaluated a patient for an hour, and I feel so guilty charging them because I didn't put my hands on them. I didn't do one test. I didn't do anything. And I said, well, what did you do? And the person said, I just listened to him and whatever. And I said, well, you should charge them double because that's what they've never gotten before. And of course, they'd been to multiple doctors, multiple physical
Yes.
therapists. And guess what? When the patient came back for the second treatment, they were better, even
Yep.
though you didn't even touch them. So that's a very powerful thing you just described.
Yeah, it is. It's especially in the emergency department when you think that the other providers don't really have time for that. For
Yeah.
better or for worse, it's not their fault that they have to make an assessment in 5 minutes or less. It's just not their fault. But if we can go in there and take that time to listen, to hear them, to help them and empower them, that improves your outcomes. It improves your patient satisfaction. It improves your provider satisfaction. And you leave at the end of the day thinking, I did something today. Not how many units did I build today, or how many like spinal manipulations did I do, or how many dry needling sessions did I perform, but like I helped actual people who were really suffering today. And the delta in one session is huge. And that's so rewarding as opposed to like incrementally inching through a rehab process, which is its own beautiful thing. But I really like to see how much of a change can I make today.
You brought back another memory that I've tried to forget. When I was when I was and I owned this clinic, and so I cared a lot about perceptions and what people thought, and so I had a low back patient. So I have seen that acute low back pain. Got the patient on the plinth on the table, and whatever triggered it, this guy went into screaming and yelling and couldn't get comfortable. There's nothing I could do. I mean, it was like, oh my God, you talk about panic, in an outpatient clinic, and people are coming around, what's going on? What's going on? And we just couldn't calm him. He was just out of his head. And eventually had to call, an ambulance. And so all I could think about was, here I'm a physical therapist trying to be with, marketing, and somebody's going to see them taking this guy out of my clinic on a gurney into an ambulance. But it was just that was scary. And I think what you're saying is you've probably seen that kind of a reaction a lot.
Yeah. And I just like how I start those interactions is like get down at eye level no matter what position that they're in, whether they're standing on the like face down, whether they're sitting, whether they're like pacing. I just try to get at their eye level and I just say, "Tell me." And they just tell you. And
Yeah.
you'll get so much just by saying that. And as the words come out, things usually decrease a little bit. And if nothing else, you're just distracting them at that moment because they have to focus on what they're saying. But a little like good hand holding and like listening goes a long way to get what you need from patients. So I always say we want to do as much as possible for the patient and as little as possible to the patient in those moments.
Yeah. You're a patient whisperer in that situation.
You know, I I think that I have developed those skills and I think they're really important for this setting. Would they be the best in everywhere? Probably, maybe not. But it's very helpful with what I do. And I will get comments from physicians who say, well, they need a little TLC, if you know what I mean. And I'll say, well, I'm not really that kind of therapist. And they'll say, but you are. So I just need you to go in there and try that. And I had one sweet, sweet young patient who said, are you a mom? Because I feel very taken care of. I was like,
Oh, that's awesome.
yes,
What
I
a
am.
great,
I'm gonna pull in the mom tricks as
great
well.
compliment. That's awesome. So, if there aren't as many PTs in the emergency departments that we'd like to see, why is that? Is it, I'm not looking for who to blame, but is it because we're not getting that kind of training or exposure information in our PT schools? Is it because the hospital systems think that's weird, and why would you put a PT in there? Why aren't we seeing that to be just a regular operation?
I think some of it is just lack of awareness. I'd say that's probably the biggest barrier that people don't know who we are, what we can do, and how we can help. So, just like every area of physical therapist practice, right? People don't know what we have to offer. We have to show them what we have to offer. Other common barriers based on the research are like physician perceptions. They don't know what we do, so they're like, "Why would we need you?" There are also administrative perceptions that we're going to increase throughput time, which hospitals obviously don't want that. That has not been shown to be the case. So I think that's part. Also, emergency departments are money pits. It it shouldn't seem like that, but they are. They are like money pits for hospitals. And so I think part of it is to, we have this tiny budget. How are we going to add a whole nother staff member here? That can be an issue for certain hospitals as well. Usually the PTs are still part of the rehab department budget, but it can cause a perception that it's going to increase cost. So those are the biggest things. There's this fear that there will be an increase in time, there will be an increase in cost. I haven't seen a lot of barriers that we're going to like we're not qualified. That's not a thing that I've run into. Like once we're able to kind of explain what we do, I've never had anybody push back on whether or not we're at a level that can practice in that setting. And I would say students don't know that this is a possibility for them. And so there aren't a ton of clinicals in this area. There aren't a lot of cases in this area. But I'm seeing that change more and more. So I do lectures for several different PT programs across the United States for many different student SIGs and things like that, just trying to increase that awareness. And I've also seen different programs putting cases into their curriculum that this patient is in the ED. It's great for differential diagnosis content. It's great for your medical conditions content. It's great for those pull it all together content moments. So I'm seeing more of that. And I actually had to resit for my NCS this year, and there was at least one clinical context where the patient was in the emergency department. So I'm seeing some like subtle shifts that make me really excited.
That's awesome. Now, do you have some kind of I want to say side hustle, but that's probably not the right term. Outside of the emergency room, do you have businesses that are related to this, related to the physical therapy profession that you're working on?
Yeah, I do, because my mission is to have a physical therapist in every emergency department and urgent care in the United States. We're behind our global colleagues, and we need to level up. And we need to be practicing at the top of our scope. So I teach continuing education courses for people who are looking to start a practice in the emergency department, for people who need to improve and learn musculoskeletal skills that are important for the ED, vertigo courses, um, practice essentials, things like that. And I have a podcast as well just to help kind of spread the awareness about emergency department physical therapy. And I also do consulting with hospital systems to either bring courses to them or to help them individually start practices so that they can improve the patient care that they're providing and so that they don't have to struggle when they're trying to implement PT in the ED. We can just do it for them so that they don't have to like go through all the growing pains of figuring that out and they can have a sustainable practice.
So tell us what your podcast name is, and those that are interested can find it.
Yeah, it's called In the ED Now. You can find it on Apple Podcasts.
Okay, awesome. That's great. And so what's the future look like? I mean, do you see yourself being in the setting for the long term? Do you see yourself opening up another kind of business relating to this? What do you think the future is for you?
Well, I've recently just this year gone down to more of a per diem role again in the emergency department and ICUs so that I can work on trying to bring this to more hospitals because I got to the point where I realized that I could keep helping one patient at a time or I could start helping thousands of patients by getting more emergency department physical therapists prepared and ready. So my goal is to increase consulting, increase education opportunities, more teaching of students, and really bring that top of scope mindset to physical therapists who really practice in any setting so that we can level up as a profession and give our patients the best of us.
I would think that, young professionals coming out of PT school, or doesn't have to be young professional, but anyone, I think would be really interested in this. You think of, job satisfaction, and people are tired of the grind in the orthopedic clinic and just, treating patients and whatever. I think this would be an exciting alternative to what maybe they're doing now. So, how do you get the word out to them? How do they know that this is something that they should maybe look into and try something new for their career?
Well, talking to as many students as possible, I think is a huge way to do that. And so every time a student group asks me if I will come and speak to them, the answer is always yes. So if you're a student out there and you're like, please, can you come talk? Yes. The answer is yes. I will do that because I really one of my priorities is to support student physical therapists. And this is one way to help share that. And one thing I say to them every time when I present to students is when you are done hearing me talk, even if you don't want to practice in the emergency department, I hope what you take with you is that we need to find better ways to get to our patients where they are and stop expecting them to come to us. And we need to be innovative and creative in the top of scope solutions that we provide. So, students, if nothing else, just know that the possibilities are endless, but we need you to pursue them, even if we didn't teach you that they exist.
Yeah, that's awesome. Well, Rebecca, in anticipation of our discussion today, what haven't I asked you that I should, or what should we know further about this topic?
Oh gosh, I would just say that one of my pieces of advocacy in this area is that we all want to be, hopefully, top of scope physical therapists, meaning like using all of our training, all of our experience, all of our what's available within our scope of licensure, and to really be the best at patient management and not be technicians. But the problem that I feel like we're running into as physical therapists as a whole is we have top of license and we have top of scope, and that those are different based on where you live. So for example, in Colorado, I can order imaging, I can dry needle, I can order durable medical equipment, I can do so many things. But in different states, physical therapists don't have that same privilege. So when I think about how do I get us all to move forward as a profession, advocacy really is so crucial so that when your top of scope and your top of license don't match, we have to get involved to push our licensure forward so that we can push our practice forward so that we can provide better care of our patients if we're really, really committed to transforming society. So I think my little soapbox moment is please, please get involved in advocacy as a physical therapist.
And you yourself have been involved in advocacy, so share a little bit with us what you do. Is it on the legislative level? I know that you're going to be the, if not already, you're the APTA Colorado chapter president, correct?
Yeah, I'm nervously beginning that at the end of this month, so that'll be
Okay.
exciting. But I'm finishing my president-elect year, and as part of that year, one of the things we did was our license sunsets. And what that means is in Colorado, every so many years, the state basically stops your license, and you have to introduce a bill to be licensed again. And with that comes a lot of work and a lot of opportunity to continue to update our licensure, to continue to move things forward, and to continue to stay current and relevant. So, one of the opportunities I had this year was to testify in front of many different state legislative committees to help move our licensure forward. So, some of the things we were able to accomplish were ordering durable medical equipment, protecting DPT in our state, and student physical therapists as well because of issues with certain fitness companies trying to use that acronym. We were able to actually protect that in Colorado. And it was so heartening to see our legislators advocating for us. But it was also a little scary to recognize that if physical therapists aren't the ones showing up to do that work, the people who decide what we do are legislators who don't know what we do. So we have to show up and be part of that process. And so that was really rewarding for me to see that if we did do that hard work, we were successful.
And I don't know you well, but just in this discussion we've had today, you're an impressive communicator. I can definitely feel the passion, and so people like you is what we need because you need to get the word out, and you need to show people that we believe in what we do. And I think if you can communicate that message and build those relationships over time, that's what it takes. And so I commend you for doing your part in your state and probably nationally, I would think.
Yeah, I've been involved in the House of Delegates as well, and that's such an interesting experience. It's so cool to have your voice heard among hundreds of PTs from across the country from so many different practice settings. So thank you. It's been a really, really eye-opening way to learn about what we do and become even more excited about where we can go.
So, Rebecca, at this point in the interview, I always ask my guests the same common question. And that question is, in relation to leadership, what is a pearl of wisdom that you could leave us with today?
Oh, it's okay to mess up. Like,
Yeah.
I think for so long I was so worried about being perfect and like that people would figure out that like I don't know that I didn't know what I was doing, and that like cost me early in my career because I was so focused on always looking like I knew what I was doing that I couldn't take any feedback, and that cost me. It probably cost my patients as well. And so I think it's okay to mess up, it's okay to fail, it's okay to take ownership of those failures and to move forward. We're all human. We just need to get better. And the only way to do that is to fail. I have a friend who always says, you know what you get when you fail? You get experience. And so I try to focus on that and use that experience to grow from it with a growth mindset.
Well, thank you for that vulnerability because that is right on. I mean, if we can all agree, which you've heard and we've heard a million times, is that we learn from our failures much more than we do from our successes.
Yeah.
If you want to learn and grow and do it on a fast track, you're going to make a lot of mistakes. And so, hopefully you look at those and you learn from them, and then that also means that you're taking risks. You're putting yourself out there. You're pushing the envelope. And someone who never takes risks and never pushes the envelope, may not fail very often, but then you might make the argument that they don't learn very fast either. So I think you said that well. Yeah. So, and I should tell our listeners too that you're going to be a speaker at the Graham sessions next January. So that's exciting. Great to have you on that. So, is there anything else we can talk about today that um, our listeners need to hear?
I think I would just say if you're feeling like a little lost and a little burned out right now, that's okay. A lot of people are feeling like that. And I just want to remind you that it's not your fault. Because I think a lot of us feel like we're doing something wrong when we feel that way. It's not your fault, and there's a way out from that. And I don't want you to give up, and I don't want you to leave the profession. I want you to keep moving forward, even if that means changing what you're doing. But don't give up. We need you. It's not your fault, but let's go.
Yeah, great advice. Well, Rebecca, this has been fantastic talking with you today. I've learned a lot, and as I said earlier, I can feel your passion, and I can see that you really believe in what you do. And it sounds like those patients are better for having interactions with you. So, thanks for everything. Thanks for your time today, and I will see you down the road in the future. So, keep doing what you're doing, and I really appreciate you being on the show today.
Thanks so much.
Take care. Thank you for listening to another episode of Profiles in Leadership. To listen to all my interviews, subscribe to Profiles in Leadership with Steve Anderson on Apple Podcasts, iTunes, and many other popular podcast platforms. Some of these interviews are on video, and you can search YouTube for Profiles in Leadership with Steve Anderson. You can also access the entire library of interviews on my website, orange.coaching.com, and that is orangetheword.coaching.com, and go to the Media Center and click on Podcasts or Video Gallery. You can also enter the website from pilpodcast.com.